Welcome back. Joining us for our first conversation this morning is Senior Minister of State and the newly appointed Chair of the National AIDS Commission, Dolores Balderramos Garcia. Good morning.
Good morning.
And she is joined by the Executive Director of the National AIDS Commission, Mr. Enrique Romero.
Morning, sir.
Good morning.
Good morning, folks.
Good morning.
Strengthening support for HIV in Belize. I don't know that it's a conversation that we've had enough in terms of being able to, one, raise awareness, and two, being able to address issues that arise out of this vulnerable population of Belizeans. Let's begin by talking about what we're doing locally. I ask for that simply because we're also aware of what's taking place within the region with the cutback on finances and funding for HIV/AIDS initiative. Let's begin there. What are we doing on the home front to be able to address these concerns?
Okay, well, we're close to 40 years into this epidemic worldwide. Now, on the local scene, from back in the early 2000s, we have had the provision free of cost to clients of antiretroviral medications. And as you know, I was the chair of the commission back then from 2000 to about 2008. So it's back again. We'll say wheel and come again. What's happening on the local scene is that we still have more or less a generalized epidemic of close to 3,700 persons with HIV that we know about. However, the trend that has been emerging is that we are seeing a more of a concentrated epidemic in a key vulnerable population, men who have sex with men. But men who have sex with men also have sex with women. And so we have the epidemic being driven now in a particular way and in a group that is sometimes hard to reach. But I must give you the good news before we go to the bad news. The good news is that we have continuing advocacy, we have continuing monitoring and evaluation, continuing coordination, and certainly since I came on at the end of April, we feel a renewed push. I mean, I'm not criticizing who went before, but I do want to take this opportunity to big up the man to my right. He has been really carrying this torch, if I could put it that way. He started as M&E, monitoring and evaluation, and then graduated to executive director. And really, he has been pushing the whole issue of the NAC for a good amount of time now. I'm pleased to really come back and to work with Enrique and our small staff at the commission. Joshua Munoz is our M&E person. Then we have Adriani Alpuche and Starla Reno. And small staff, and really we are a secretariat. But what we have tried to do in just the past couple of months is to really revitalize the commission members. Because as you know, and of course we'll have a little more chance to talk about it, but as you know, we absolutely need partners. And of course, the main partner has to be the Ministry of Health.
Isani just spoke about some of the cutbacks that we have observed coming from supporters to us here in the region. But one of the things I also want to highlight is the way that Belize has really set the pace when it comes to trying to tackle HIV here locally. How would you compare that to other countries in the region?
Oh my. Well, we know more about the local situation than we know about the international situation. But I believe I can tell you, and I'm sure Enrique will back me up, that in particular places like Trinidad, Jamaica, Guyana in particular, they have really managed to have a set of responses that is effective, because in Guyana is a huge country, and they actually go out to clients. They actually go out to clients. We need to really start doing that, because we have a lot of HIV in our rural areas. The districts, as we know, more affected are the Belize district, Cayo and Stan Creek. Not so much Orange Walk, Corozal and Toledo, but that doesn't mean there's not there. It's just, and the main district where we are seeing a lack of adherence to the antiretroviral medications is the Belize district. And
Is it that?
there may be various factors. But you did ask about the international situation, and it is challenging because of cuts coming now from the United States wanting to cut budgets all over the place.
They've shuttered USAID, which was one of the biggest funders.
Yes, indeed. And I mean, but the good thing about Belize is that we cover between 80 to 85% of the cost of responding to HIV, and we really have to find new ways now of reaching the populations that we need to reach. Let me just reel off a statistic for you. About 80% of people, correct me where I go a little off, Enrique, but about 80% of people living with HIV know their status. So we have to plug that 20%. Secondly, only about half of that number are on antiretroviral medication. So what do we do to make sure that we increase that? Because when you increase treatment, you're also increasing prevention.
Yes.
So we need to get the people on ARVs more. And then the third aspect, which is very challenging, is that only about 1/3 or about 32% of people with HIV on the medications are virally suppressed. Because when you're virally suppressed, well, we know the not the math, but the medicine of it. When you're virally suppressed, you can't transmit.
That's right.
So that is a way of prevention. And that is really what we need to get to, where the goal worldwide is for us to get to what you call 95, 95, 95. By 2030, we would want 95% of people with HIV knowing the status, 95% on ARVs, and 95% virally suppressed. Now, it's a tall order.
Yeah.
It's
Very
a tall order.
Let's go back a bit. You mentioned that in Belize district, persons with HIV are not necessarily accessing treatment and what have you. Is it because there is still this stigma about being HIV positive that people are not trying to put themselves or their business out there, so to speak, as to why they are not accessing the treatment the way they ought to?
Well, Isani, there are several factors, as Minister alluded shortly a while ago, and we have realized that the epidemic is multifaceted, meaning that it's no longer just biomedical, it incorporates the social protection component. Studies have been done, and for example, Belize, the adherence rates are very low. We look at, you mentioned about stigma. One of the things that we are battling with, which is even more difficult, is the internal stigma, the internalized stigma. So a client goes to a clinic and feels as though he or she may not be treated properly, he or she may have to wait longer than others. So what we have been focusing now is what we call differentiated service delivery models, whereby it's no longer business as usual. We can no longer say, okay, we have 80 health facilities countrywide. If you need a test, if you need medications,
Go there.
just go to any clinic. No, what, as Minister said, we're trying to now, as Guyana is doing, take the services to those hard-to-reach populations. We are introducing new initiatives, HIV self-testing, which is swabbing of the gums, so you can pick up an HIV self-test, take it home, take it for your partner or partners, do it in the comfort of your home, privacy, and then we try to link you to care. So these are some of the initiatives that we're trying to implement and introduce in the country that will allow people to access the services that they would normally not access in a public health facility.
You spoke about 1/3 of the persons that are infected with HIV
Virally suppressed.
Of that 1/3, how many of these persons, or what's the percentage of the persons actually getting treatment?
Well, like I said, when we look at the continuum of care cascade, the three pillars, the first pillar speaks to testing. So we're at about 83%.
Okay.
Knowing their status.
Okay.
The second pillar, which is treatment and retention, adherence, people sticking to their medication, we're at about 50%, which is not good, because we have another 50% not taking medication, not adhering.
Right.
And we only have 1/3, 30% of those who know their status who are virally suppressed. So, and that's our end goal, to get people virally suppressed. As you may have heard, the U equals U, the undetectable equals untransmissible, and that's our ultimate goal. And that can only come if you adhere to your medications, the time, and
What are you guys observing in terms of adherence to medication? Is it because perhaps some people, or perhaps medically, they still have to take an entire cocktail of pills, or is it that now
No.
everything has reduced to perhaps 1 or 2 tablets, but
Yes,
people
yes.
people just don't find themselves changing their behavior in terms of
Right,
access?
right. Well, it's one pill, but it's a big pill. They talk about literally a big pill to swallow, so they could cut it or whatever. However, what we're finding is that the lack of adherence does have to do with the socioeconomic condition of many people.
Okay.
We just had a very good meeting with some of the doctors and Nurse Ortega 2 days ago. And basically what we're saying is what we need to do is to ramp up the responses of partners, especially the Ministry of Human Development, who provide food packages and that kind of thing, for not only for adults but also for children with HIV. And basically we need what you call adherence counseling. Now we can't put all of that on the Ministry of Health. They simply don't have the situation, the ability to do it. So what we're looking at is for other partners to come in. BFLA, very good partner. The Go Hoven Belize, very, very good partner in the NGO community. But really, it's the Ministry of Human Development on the government side that we really need to come in and assist our Ministry of Health people. And I do want to say that for some reason, prior to my coming on, there was a reticence on the part of the Ministry of Health to roll out what you call the self-testing kits. Now we have changed that policy. We've changed it. I mean, we really had to bring even the Prime Minister himself had to be made aware of this, because the National AIDS Commission comes under the office of the Prime Minister. And we went right to the top and we said, this needs a policy change. We also went to the Minister of Health, Minister Bernard, and luckily there was good acceptance of the recommendations. And now we have full acceptance of the self-testing kits. We have what you call PrEP, which is pre-exposure prophylaxis medications. And we also have the post-exposure prophylaxis medications, and those medications are used in rape kits as well for somebody who has been sexually assaulted.
How popular is the PrEP pill? Do we see that a lot of people tend to purchase it?
Many people don't know about it, but now that we are promoting and advocating, I think more people are becoming aware.
And just to mention, it's not to purchase, it's again free of cost. By the government of Belize through the Ministry of Health Facilities.
Okay.
And again, the PrEP, just to clarify as well, it's not like a magical pill, it's part of a combination prevention approach. So we still promote and advocate for the proper use of consistent and proper use of condoms every time you have sex with your partner. And in addition, then you have the pre-exposure prophylaxis. Because let me tell you, the pre-exposure prophylaxis can't protect you against HIV, but it can protect against pregnancy and other STIs. So it's, like I said, it's part of a prevention combination approach.
Right.
You mentioned earlier the fact that there's a population of about 3,700 persons who are infected. What does this represent over perhaps the last 5 years? Is it an uptick? Is it something that has come down? Or where are we in terms of the overall picture of infections?
Unfortunately, it hasn't really come down in the way that we would want to see it come down, because with 200 new infections per year,
yeah.
we're still not reaching everybody that we want to reach. But if we can bring that down to, say, 100 new infections per year, we would have increased the effectiveness by 100%. Now, again, how do we get people retained in care? How do we get people retained in care? And we just can't say it enough. I mean, our girls at the office are very, very good. We're working on some new advocacy campaigns to reach young people. In other words, if you're going on the road, be ready for the road, that kind of thing. That speaks to our younger population. But unfortunately, in terms of new infections, it's about 2/3 of those new infections are in young gay men and young men who have sex with men, and men who have sex with men. Some young men sell sex. You know, it is a matter of, again, I can't stress enough, the socio-economic situation of many of our people that we have to try to plug and to cover. And I have a good feeling, I have a really good feeling about the cooperation of our partners. We're reaching out to the churches, we're reaching out to the schools. I feel a sense of okay, this is something that we have continued to be all in together, and we have to try to make things better. We simply have to make things better.
What about the mortality rate in terms of persons who are dying from HIV/AIDS infection?
Well, in terms of the data, that was also, over the past 5 to 10 years, as Minister mentioned, we have been, the new infections kind of plateaued. We were around 200, 220, 225, and alarmingly as well, you had about 100, 105, deaths per year. So when you look at the raw numbers, you could say that, of the people that get infected, half of those would have died from AIDS-related causes. So hence the reason why we need to advocate for greater prevention measures, to advocate for partners to be more involved. Just want to mention as well that we were about to sign this week a memorandum of understanding between the Ministry of Human Development and the Ministry of Economic Transformation, who is the principal recipient for the Global Fund grant. And the MOU will speak to more support being provided by Ministry of Human Development, particularly through the provision of nutritional packages for persons living with HIV, because this was one of the activities that was part of the Global Fund grant, and Global Fund said, look, we can no longer continue that. So through Minister's leadership, we were able to get government to absorb that particular activity. And just to mention that these are some of the things that makes us puts us in a better position than other countries, that ever since we have been getting Global Fund grants, the government has been expected to co-finance the grant. So every 3 years, we have been absorbing part of the activities that were once funded by Global Fund. So we like I said, we are in a better place than many
Socially.
I'd like to talk about the need to provide the additional support to persons living with HIV. You spoke about food packages and whatnot, but my understanding is if you take your medication to time, you could live a relatively normal life.
Absolutely.
So
Absolutely.
Speak to the additional support that is given regardless.
Again, this is where we need the adherence counselors and the help of our civil society partners. Social marketing, I think, is what we call it. Right. That government will come to agreements with the people and the organizations who can really help. And one of those organizations naturally is the whole NHI and the clinics that are opening. I can think right now of the NHI clinic in Ladyville. I mean, we have hundreds and hundreds of people going to Ladyville now for the NHI clinic. And when we have an agreement between, say, the Ministry of Health and the NHI clinics, that will be able to give the help, I do want to, if you allow me though, to touch, since we don't have much time, I do want to touch on this issue of access to sexual and reproductive health care for minors. Now, it can be a little bit of a hot potato, because we will get some pushback from the conservative elements in our country, but it is something that is absolutely essential. Yes, we did raise the age of marriage, which is a contract, to 18. That's so you can't get married at 16 now with parental consent. However, the age of consent to sexual activity is 16. Let me speak for myself. I don't think we should tamper with that, because we would be getting ourselves into a situation that we cannot police.
In what sense?
We can't police it. The age of sexual debut for many of our children now is 13, 14, 15. You see? I think what we should do, now I'm getting on my little soapbox here, but I think really what we should do is allow for the access to sexual and reproductive health care for our young people. Not 12, but certainly when you're 16, 17. There is a test in England. There was a case in England, and it's called the Gillick competency test. If a young person, 16, 15 and a half, 17, has the understanding of the risks that they may be in, then we ought to be able to provide that sexual and reproductive health care. And we have sought an opinion from the Attorney General's office, and that opinion is that Belize could adopt the Gillick competency test and the sexual and reproductive health care for young people. We can do so by regulations that would come under one of our acts. You know, we wouldn't necessarily have to put in legislation, but we could do so with regulations. And I think that would probably be one of our next policy moves. I do want to say something, though, in terms of clearing the air. I didn't hear Pastor Louis Wade personally, but in one of the tabloid media, they said something about how Pastor Louis Wade lashed out at me because I blocked a push to raise the age of consent to sexual activity from 16 to 18. No such thing, right? So I'm clearing that air, and I'm speaking personally for myself now. I blocked nothing, and I'm not aware that there was any push to raise the age of consent to sex from 16 to 18. But why do I bring this up, gentle people? I bring this up because we have to reach the people who need it the most. And our young people need to access the care. No, we are not taking away parental responsibility. Far from that. But what we would do is use a competency test for a young person who, that young person may be pregnant and the mom don't even know.
Yeah.
That kind of thing, or may have been sexually assaulted, or may have to access the clinic for an STI, a sexually transmitted infection. So we're talking the real on-the-ground stuff. Some people don't want to touch it. Some people don't want to touch it, but when you talk HIV, you're talking sex, you're talking responsibility, you're talking all the things that are the difficult social issues that we need to address.
So before we end the
before
conversation,
we wrap up,
I want to circle back to one fundamental thing here. Is it that in 2025, discussing HIV/AIDS is still very much taboo in our Belizean society? Or is it that we've opened it up now to where we're a bit more comfortable having these discussions openly?
Make you answer that one.
It may still be a taboo. However, I think we have made progress in terms of opening the discussions, and that has come about through the work that we do with many of our partners. For example, one of our good practices in the region is working with the business community. So we worked with the Chamber of Commerce, Ministry of Labor in putting together HIV workplace policies. So we had companies from the private sector who came on board, and they worked in developing an HIV workplace policy for their own organization. And the policy basically speaks to the company providing services to persons infected or affected by HIV. So that's something good, because the employers can support the employee rather than getting rid of the employee, which would have been the normal case in past years. No, so that also helps too.
Well, we're reaching out to the hard to reach communities as well. We've met with the UNIBAM people. Well, for want of a better term, I don't want to call names, but we've reached out to some of the organizations that would normally assist us to reach the hard to reach populations. And yes, there is still the stigma, but I think, as Enrique is saying, that we're getting to a point now where there is more of an openness. And I want to take this opportunity to really thank all our partners. I mean, the Ministry of Health, I can't say enough. Dr. Melissa Diaz has been extremely helpful. Dr. Marvin Manzanero, there's a new focal point coming on now, Dr. Joshua Canul. And then we met with Nurse Ortega. Nurse Veronica Ortega is passionate about the work that she does and needs help. So we're pushing for the Ministry of the Public Service to accept and to process the appointment of new adherence counselors for countrywide, so that we can really help our people. So I can't say enough about thanking our partners and getting that renewed push in fighting HIV, because it is still very much of a struggle.
Well, we appreciate you both taking the time to have this conversation with us and speak about where Belize is as it relates to addressing HIV, and of course, using that opportunity to encourage partners to come on and support as well.
Right.
Thank you so much.
Thanks for the opportunity.
No trouble at all, and thank you very much for the opportunity. Anytime you want us to come back, we will, because it's our work, and we have to remain passionate about our work and make sure we get it done.
One more thing, Minister.
One more thing.
We discussed about having a session with the media.
Yes.
So to sensitize the media in terms of the work that the NAC and its partners are doing. So that's as well in the pipeline. Sessions with media, with key partners as well. Yeah.
Yes.
Well, we appreciate the invitation.
Yes, we will. We'll get back to
Definitely.
you.
All right, we take
Thank
a
you.
quick break now, but don't go anywhere. When we come back, the conversation switches into the Belize Chamber of Commerce, engaging communities with vibrant cultures and entertainment.